Ну что, через 3 минуты могу начинать, да?
Ну, можете и сейчас начать, они могут отматывать.
Все, то есть тут ничего не надо делать, они меня уже слышат.
Да.
Спасибо большое, Дима. Начну, наверное. Так, сколько? 13:48. Четко как. So, good day, my dear colleagues. I see you already prepared for the lecture. Glad to see you on this side. So, let me start lecture for today. And the topic for today is isoimmunization in pregnancy or immune incompetence in pregnancy. Immune incompetence in pregnancy or incompatibility in pregnancy include a number of syndromes because of number of factors, but today we will tell about one part of this problem. It would be blood incompatibility in pregnancy. So first of all, about definitions. What does it mean, blood incompatibility? It is also known as isoimmunization or maternal blood group immunization. It is the development of circulating antibodies by the mother directed against the antigen of the fetal origin. Isoimmunization is also referred to as maternal sensitization. Isoimmunization in pregnancy most often involves the rhesus system of red blood cell antigens, but it can also involve ABO antigens and other blood group incompatibilities. Here are presented most famous types of isoimmunization which you can face in pregnancy while you will make your professional job. Rhesus factor, ABO, calcium system, Duffy, C known as little cm, platelets, and so on and so on. All of these points may lead to development of isoimmunization, and the main principle of this isoimmunization is conflict between fetal antigen and maternal antibodies, which are released by maternal organism as a reaction to the presence of foreign antigen in maternal organism. First of all, what is medical significance? Social, economical, clinical significance of this situation. As about clinical significance, fetal red blood cells, RBCs, which possess an antigen that the maternal mother lacks, can cross the placenta into the maternal circulation, where they stimulate antibody production. The antibodies return to the fetal circulation and result in RBC's destruction, also known as hemolytic disease. Hemolytic disease may affect fetus, but mostly we're speaking about hemolytic disease of when newborn. Well, we've got newborn just after delivery and are able to confirm direct diagnosis. I had to be able to confirm correct treatment to save newborn's life. As about social, economical significance of this situation. On one hand, marriage of rhesus negative woman, rhesus negative man lead to appearance of higher risk for development of isoimmunization, not only rhesus but any other groups of blood. Isoimmunization during the pregnancy and isoimmunization during the pregnancy lead to declining of the rate of childbirth. It is lead to failure of the health of newest population, and it is followed with lack of properties of life both of children and mother. That's why we had to be able to confirm correct diagnosis, to make treatment and maybe more effective to prevent such a situation. But prevention just of this point is not dependent on us only. That's why we had to know what is this syndrome. As about synonyms, number of synonyms are used all over the world, and you may face number of synonyms in special literature. Most frequent term which is used for this situation is isoimmunization in pregnancy, rhesus immunization, rhesus incompatibility, hemolytic disease of the fetus or hemolytic disease of a newborn, also known as erythroplastosis fetalis, hydrops fetalis, blood group incompatibility, and so on and so on. And here is the picture showing that antibodies attach the antigen on surface of RBCs, and it is followed with development of isoimmunization symptoms. Isoimmunization itself in pregnancy, as I'm already told, first of all lead to lack of reproductive function in population in this part of population of the earth. It is lead to appearance of number of complications during the pregnancy because it is worsening the course of gestation process just from the very beginning, from fertilization up to delivery, and later postnatal complications are very frequent because fetus, newborn, delivered with affected blood system. Newborn will be delivered with affected development of vital organs. That's why it is of great importance, and we are starting to discuss it in the fourth course as one of the most frequent situations which may meet. So, we distinguish fetal complications and maternal complications which may take place during the pregnancy, and they are related to the development of rhesus incompatibility or ABO incompatibility in pregnancy. So, first are fetal complications. As agglutination reaction which is taking place on the surface of RBCs of the fetus blood. As it is followed with development of destruction of RBCs, they are not able to make their function, and fetus will start to suffer from a number of symptoms and syndromes. Fetus will start to suffer from hemolytic anemia. Fetus will start to suffer from increased level of bilirubin, which appear because of destruction of hemoglobin due to just this reactant of agglutination. Fetus will present hemolytic anemia, will present icterus jaundice, will present hydrops fetalis, as we know. But before even development of this manifestation of fetal compromising in pregnancy with patient with isoimmunization, fetus will start to present just obstetrical complications, obstetrical syndromes which are taking place during the pregnancy. So these are fetal distress. Fetus is suffering from lack of oxygen consumption because of lack of hemoglobin due to hemolytic anemia. Fetus will start to suffer from intrauterine fetal growth restriction. An abbreviation of intrauterine fetal growth restriction syndrome is shown here, IUFGR. Intrauterine fetal growth restriction followed with delivery of a newborn with less body weight. Less body weight means more problem with further development after delivery. Intrauterine death may take place because of progressive development of hemolytic disease of the fetus, or preterm interruption of pregnancy. Maternal complications. Preterm interruption of pregnancy is one of the most frequent situations, and I want to add to those which is written here, these words, that preterm interruption of pregnancy in patients with fetal, not with hemolytic disease but isoimmunization, may take place at any time of pregnancy. Preterm interruption is spontaneous, which is just related to development of isoimmunization complex during the pregnancy. Thus, patient may have early miscarrying of pregnancy, may have later miscarriage, she may have preterm labor. All of them may be characterized with loss of child, or may followed with lack of properties of the life of children in further life. Prevention of isoimmunization helps to improve the fetal, newborn and maternal health and responsible for the property of life of population in the country in whole. As about maternal complication, not only preterm interruption of pregnancy, but it is known already statistically that preeclampsia syndrome incidence is significantly higher in categories of patients who are suffering from isoimmunization during the pregnancy, and not only higher in absolute percentage, but the presence of severe forms of preeclampsia syndrome in such category of patient is significantly higher than in other categories groups of patients who may suffer from preeclampsia syndrome. Maternal anemic syndrome, it may predispose it to have been present as chronic pre-pregnancy condition, but it may take place just during the pregnancy. And of course, intrauterine fetal death. As you can see, division of complications which are develops during the pregnancy in relation to isoimmunization to fetal and maternal is only theoretical, because practically we have no possibility to divide it into two groups, and we had to understand that just obstetrical complications may take place in pregnancy, and most of them are followed up without special correction, without special management and treatment, will followed with fetal death and loss of pregnancy. So we had to understand our main idea for today, to understand what is isoimmunization, main clinical presentation, and most important maybe theoretically, schematically, we had to imagine what we will do, what are steps of our working with this patient if we will have this patient in our practice. So first of all, to understand it in detail, some words as an introduction. Blood groups were discovered by Landsteiner. Two major classification systems are used for grouping blood. They are based on the presence of different antigens in the blood cells. These systems are the ABO system and the rhesus system. I saw you already previously slide where I presented a number of other systems, but these are most major classification. According to the ABO system, the blood group can be classified as blood group A, B, AB, and O, 0. You already know it. You've got this knowledge during your previous years of working, studying in the university. And here is presented the table which demonstrates combination of different alleles of these antigens. So, as you already understood, blood group means that these people contain antigen A in their blood cells and antibody anti-B in their plasma. People with blood group A can receive and give blood to people with blood group A only, provided they are compatible for rhesus factor. It is absolutely used nowadays. Blood group B. These people contain antigen B in their blood cells and opposite the antibody anti-A in their plasma. People with blood group B can receive and give blood to people with blood group B only, provided they are compatible for rhesus factor. Blood group AB. These people contain both antigens A and B in their blood cells and none of the antibodies in their plasma. People with blood group AB are known as universal recipients, as they can receive blood from any person belonging to any of the ABO group with matching rhesus status, of course. This is so as their blood doesn't contain any antibodies, so there cannot be any reaction with any of the antigens present in the donor's blood. And at last, blood group O. These people contain none of the antigen A or B in their blood cell, but contain both the antibodies anti-A and anti-B in their plasma. People with blood group O are known as universal donors classically, and they can donate their blood to a person belonging to any of the ABO system group with matching rhesus status. Thus, people with O blood type can donate blood to people with blood group A, B, AB, or 0O. However, compatibility with other antigens like rhesus needed to be matched. This is so as the above blood doesn't contain any antigens, so there is no reaction with any antibodies present in the recipient's blood. These are Main rules, basic fundamental knowledge according to the antibodies, antigens of human blood. And here is presented rhesus system and blood grouping of the ABO blood group system. The next most important blood group system is rhesus blood group system. Though the rhesus system contains 5 main antigens, which are presented here, antigen D is considered to be the most immunogenic. There is no specific for D antigen, specific antiserum. The letter D, small letter D, indicates the absence of a discernible allelic product. According to the rhesus classification, the blood group can be basically classified as rhesus positive and rhesus negative. The major rhesus system antigen is the D antigen, and it is found in 85% of the population of the Earth. Anti-D antibodies are immunoglobulin G antibodies that bind to the surface of the red cells, resulting in deformation of the cells. These deformed red cells are then sequestrated in the spleen, resulting in delayed extravascular hemolysis. It is now known that the rhesus system is very complex and there are other antigens beside D antigens. Some important rhesus antigens include C, D, and E. Since there are 2 possible alleles for each antigen, C, D or D, E or E, and haplotype consisting of CC, DD, and EE inherited from each parent. The resulting rhesus type of individual depends on their inherited genotype. If an individual's rhesus genotype contains at least one of the C, D, E antigen, they are rhesus positive. Rhesus positive people contain rhesus antigen in their blood cells. RBCs of such individuals are agglutinated by antiserum against D antigen. Rhesus negative in their blood cells. Rhesus positive contain rhesus antigen in their blood cells. RBCs of such individuals are agglutinated by antiserum against D antigen. Rhesus negative people do not contain rhesus antigen in their blood cells. RBCs of such individuals are not agglutinated by the antiserum. Individuals with rhesus negative blood normally do not have antibodies against rhesus antigens. However, these people may develop anti-rhesus antibodies if they receive exposure to the rhesus antigen. For example, transfusion of rhesus positive blood. Thus, people in a transfusion of rhesus positive blood made it once in the previous life of our patient or her further life, she will get antigen. Maybe minimal threshold level, but they would evaluate it again and again in this blood. Thus, people with rhesus positive blood can safely receive blood from the people with rhesus negative blood, but people with rhesus negative blood must not receive blood from rhesus positive people, as they will develop anti-rhesus antibodies on receiving rhesus positive blood, which will follow with development of agglutination reaction. If these people receive rhesus positive blood the second time, there will be a reaction between the rhesus antigen of the donor and the anti-D antibodies already present in the recipient. And the above mentioned scenario can also occur in the rhesus negative woman if they bear a rhesus positive child. This is the mechanism, pathogenesis of development of so-known isoimmunization in pregnancy, which is leading to lack of pregnancy, to lack of the pregnancy cause, which is leading to lack of the development of the fetus in the uterine cavity and lead even to the antenatal, intranatal and postnatal death of conceptus. So, let me try to make summary about pathogenesis. 2 types of incompatibility diseases can occur most frequently in our practice: rhesus incompatibility disease and ABO incompatibility disease. Both diseases have similar symptoms, but rhesus disease is much more severe because rhesus antibodies cross over the placenta more readily than anti-A and anti-B antibodies. Rhesus incompatibility may develop when a woman with rhesus negative blood marries a man with rhesus positive blood and conceives a fetus with rhesus positive blood group. One of the most frequent mistakes which we are getting during questioning on our patient: what is the mechanism of development of rhesus incompatibility? In what cases the couple may have rhesus incompatibility during the pregnancy? And the most frequent answer is rhesus positive father, rhesus negative mother, and if they will marry, conceive, they will have rhesus incompatibility. Incompatibility will appear only in one case: when rhesus negative mother pregnant with rhesus positive fetus. If the fetus is rhesus negative, no problem in this case. Even more, we still don't know exactly what is the pathogenesis and real reason of development. I mean, the next. Only 25% of patients who are rhesus negative pregnant with rhesus positive baby. While carrying pregnancy, only 25% of them presenting development and manifestation of rhesus incompatibility or rhesus isoimmunization in pregnancy. So, rhesus positive fetal red blood cells from the fetus had to enter across the placenta into maternal woman's circulation system. And when they are entering the maternal organism, as a result, as a reaction to appearance of foreign body, foreign antigen, maternal organism start to release antibodies. These antibodies in this turn had to pass to the fetus, and if they would fix located on the surface of RBCs of the fetus blood, in this situation, agglutination between fetal antigen on the surface of RBCs with maternal antibody on the surface of the fetus RBCs will lead to destruction of RBCs with development of hemolysis, anemia, hypobilirubinemia, hypoproteinemia, followed with development of jaundice and hydrops fetalis. Exactly, throughout the pregnancy, small amounts of fetal blood normally can enter the maternal circulation. It is known as fetal-maternal transfusion or fetal-maternal hemorrhage, with the greatest transfer occurring at the time of delivery or during the third trimester. I am paying your attention again and again. Any conceiving, any fertilization pregnancy had to have its outcome. And the outcome of any pregnancy, and depending on the type of outcome, premature labor term, cesarean section, artificial abortion, spontaneous abortion, any outcome is followed with rupture of membrane connecting placenta with maternal surface of the uterus, internal surface of the uterus, and it is followed with appearance of fetal maternal hemorrhage. Even during the pregnancy, small amount of fetal blood can enter the maternal circulation, but most of them are entering closer to the labor normally they are entering during the labor process. First, second and third stage of labor. This transfer stimulates maternal antibody production against the rhesus factor, which is called isoimmunization, as we already understood. The process of sensitization had no adverse health effect for the woman. During the time of the first rhesus-positive pregnancy, the production of maternal anti-rhesus antibodies is relatively slow and usually does not affect this pregnancy, the first pregnancy, if everything is okay, if the course of pregnancy is not complicated. Rhesus incompatibility is not a factor in the first pregnancy because few fetal blood cells reach the mother bloodstream until delivery, only few. The antibodies that form after delivery are presented in large amount, but they cannot affect the first child because child is already out, it is just expelled. However, if the mother is exposed to the rhesus D antigen during subsequent pregnancy, the immune response is quicker and much greater. But in case only when the second pregnancy is with rhesus positive fetus, If the second pregnancy, during the second pregnancy, mother carrying rhesus negative fetus, no problem will appear in this case. The antibodies that form after delivery are not affecting the fetus, the child which is already expelled. However, if the mother is exposed, she already released, and during the next pregnancy, it will become more progressive development of this situation. The anti-D antibodies produced by the mother can cross the placenta and bind to the rhesus D antigen on the surface of the fetal red blood cells, causing lysis of the fetal cells BCs, resulting in the development of hemolytic anemia. Severe anemia can lead to fetal heart failure, can lead to fetal fluid retention, and hydroxyl and intrauterine death. What are functions of RBCs? The function of RBCs is transport of oxygen, and if RBCs number are lack, if RBCs are destroyed, oxygenation of the fetus will suffer. We will get hyperoxygenation, which is not dependent on oxygenation of maternal organism. We may add oxygen more to maternal organism, but there is no target for this oxygen. No hemoglobin in the fetus RBCs, no normal RBCs in the fetus blood, which can transport oxygen to the fetal cells, tissues, and organs, and development of the fetus will failure, arrested, leading to the death. If there is hemolysis, it is followed with destroying of hemoglobin, and it is followed with increasing of the level of indirect bilirubin. And it is dependent not only on hemolysis, hemolytic process which is taking place in the blood due to agglutination reaction, but at the same time it is followed, appeared massively because of lack of the function of liver of the fetus, which is suffering from hyperoxygenation. And secondary, it will lead to appearance of higher level of bilirubin. And later it would be transformed into direct bilirubin, and direct bilirubin in its turn will lead to intoxication of whole organism and dysfunction of number of systems, mostly central nervous system, and fetus is not viable in this case. Lack of function of liver lead to hyperproteinemia lead to arresting of fluid in the organism, in interstitial tissue, then in cavities of the fetal organism, and it is followed with development of so-known hydrops fetalis, generalized edema of the fetus. And this is additional reason for the fetal death. But we had to understand that even at first pregnancy, in rhesus-negative woman with rhesus-positive fetus, the cause of pregnancy may be complicated with development of isoimmunization because of increased volume of fetal maternal hemorrhage if. What are reasons of increasing of the volume of fetal maternal hemorrhage during the pregnancy? Let we imagine that it is first pregnancy, she is pregnant with rhesus-positive fetus, but something happened during this pregnancy and she has, for example, lack of progesterone during the pregnancy. Due to hormonal disbalance, she may have increasing of uterine contractions, and it is followed with threatening of pregnancy. Threatened miscarriage may happen. Threatened miscarriage usually characterized with increased uterine tonicity and rupture of microvessels. It may be ruptured in micro areas, it may be ruptured in very small amounts, but in this case we already got an entrance of the fetal antigen into maternal circulation, and threatened miscarriage is one of the reasons of appearance of isoimmunization during the pregnancy, even if it is even first pregnancy, but pregnancy with rhesus-positive fetus. What do I mean? For example, patient is rhesus-negative, she became pregnant, she has now, it is the first pregnancy, she had no any problems. We tried to check up presence of antigen in maternal blood. We didn't find it, but unfortunately, threatened miscarriage happened. And patient came to my office with complaints, for example, about hardness in lower abdomen, pain in abdomen, constriction feeling of a stone-like uterus in abdomen, pain in low back, maybe appearance of insignificant blood staining discharge. It is known as threatened miscarriage. What do we usually do? We administer bed rest, we administer spasmolytics, sedative drugs, administer progesterone. We are trying to save this pregnancy, but on the other hand, we yet to save this pregnancy exactly. But on the other hand, it is already reason which is leading to appearance of rhesus isoimmunization just during this pregnancy, already throughout this pregnancy, during the first pregnancy, if it is the first pregnancy, and further management had to be specific if we already know it. That's why we are learning it. The next is uterine hypertonicity. Again and again throughout the pregnancy, uterus presenting hypertonic condition. We are making ultrasound control, we are making objective exam. Hypertonicity of the uterus, increased irritability, the same reason which is leading to appearance entrance of small amounts of blood into maternal organism and development of antibodies. And if it is happened throughout the pregnancy, long duration of this situation followed with means enough time for development of agglutination and affecting of the fetus throughout the first pregnancy. Thus, it is rule, first pregnancy is not object of isoimmunization, but only in case when there are no specific obstetrical complications which are followed with increased amount of blood which may enter maternal circulation. Hypertensive disorders in pregnancy. Hypertension characterized with increased tonicity of blood vessels in the area of microcirculation of the fetal-placental complex. Hypertensive disorders, most frequently it is preeclampsia-eclampsia syndrome, but may be superimposed. Preeclampsia is superimposed on chronic hypertension. Thus, this patient will have hypovolemia. This patient will have increased tonicity of vessels, irritation of the endothelial system, increased permeability of the vessels wall, and it is followed with the increasing of the amount of fetal maternal hemorrhage which will take place during the pregnancy. No bleeding at all. No internal bleeding, no external bleeding, but there is component which is leading to increasing of the amount of blood which is entering maternal circulation. And the reaction of development of antibodies is already started, and there is target inside this organism, which are red blood cells of the fetus, which is located in the uterine cavity. The next is extragenital disease decompensation. Would you like to imagine patient with diabetes mellitus? Diabetes mellitus itself is characterized with angiopathy, vasopathy, neuropathy. Thus, it is just basis for increased permeability, for rupture of small vessels, insignificant, and increasing of increased amount of blood into maternal organism, as well as inflammatory diseases, other immunological problems, hemacoagulation disorders, both congenital and acquired, and so on and so on. Placenta previa, placental abruption, characterized with the main symptom which is bleeding, hemorrhage in pregnancy. This bleeding may take place into the uterine cavity, as well as it may be external vaginal uterine bleeding, and of course mixing of blood of the fetus and mother, or entrance of the fetus component into maternal circulation will lead to development of the same problem even in the first pregnancy. As you can see, all of these features which are presented here followed with increased volume of the fetal maternal blood transfusion per dozen, rupture of microvessels, increased permeability of membranes, angiovasopathy, etc., etc., followed with the release of antibodies which, if they will cross through the placenta, they will lead to agglutination. Thus, the next step, they had to cross into the fetus blood RBCs through placenta. And the next important moment which is responsible for development or not development of isoimmunization in pregnancy is placental structure, placental development, and placental barrier function. How does it mean placental barrier function? And most often, placental barrier function is better in patients who were previously healthy without angiopathy, vasopathy, and so on, without metabolic disorders. So, as about clinical presentations in pregnancy, rising up of the antibody titer, we had to check it out, make constant control, and appearance of obstetrical signs. Fetus growing, rate of the growth of the fetus is not correspondent to normal diagram of the fetal growth. Intrauterine fetal growth restriction. Fetal distress, we can evaluate it with the help of fetal kicks movement. That's why we are making it from 20 to 22nd weeks gestation. We can evaluate it with repetitive special investigation of the fetal condition with the help of Doppler investigation, with the help of biophysical profile, as we told during our practical class. You will tell about it during your practical class. Cardiotocographic exam, intrauterine fetal growth restriction, I already told, and threatening of pregnancy. Symptoms of pregnancy threatening. Thus, if practitioner is attentive to the cause of pregnancy, he will not miss appearance of any of these situations. And even if there are no these signs, be attentive please and try to exclude it while you are managing pregnancy in patient with rhesus negative blood group. As about clinical manifestation of erythroblastoma fetalis, they include hydrops fetalis, icterus gravis neonatorum, and congenital anemia of the newborn. Or in Russian classification, we distinguish hemolytic anemia of a fetus, hemolytic anemia of a newborn, hemolytic anemia of the fetus with icterus, bilirubin of both fetus or a newborn. It is only staging, and hemolytic anemia with hypericterus and hydrops fetalis. Hemolysis often results in hyperbilirubinemia, as already told. Low level of the jaundice are not harmful, but if left untreated, high levels may develop, resulting in damage to specific areas of the neonatal brain, which are characterized with a number of lipids, confirming this tissue, causing permanent brain damage, kernicterus. This can lead to a range of neurodevelopmental problems such as cerebral palsy, deafness, and motor speech delay. Isoimmunization depends on the volume of fetal blood entering the maternal circulation. I repeat it again, please pay attention. Isoimmunization depends on the volume of fetal blood entering the maternal circulation. And isoimmunization usually occurs when at least 0.1 milliliter of fetal blood enters the maternal circulation. Would you like to imagine this amount of blood? 0.1 ml of fetus blood. When enter the maternal circulation, it will lead to development of isoimmunization. But I repeat again, fetal maternal hemorrhage time to time may take place during pregnancy. If it is less than 0.5 ml, microscopic, it may not follow with manifestation of isoimmunization. We will tell about it. Changes of rhesus isoimmunization. In antenatal period, due to the fetal maternal hemorrhage, are about 1% to 5%. Whereas that during the end of the third trimester of pregnancy and just at the time of labor are about 10 to 15%. Isoimmunization can also occur following medical interventions such as corneal villus sampling, amniocentesis, external cephalic question, etc., etc., and other medical events like pregnancy termination, late miscarriages, antepartum hemorrhage, abdominal trauma, which can cause fetal maternal hemorrhage. What is the conclusion in this case? If your patient is rhesus negative, and depending if she is pregnant with rhesus positive or rhesus negative blood, try to avoid to make such an intervention. Try to avoid the development of such a situation, which is characterized with the increasing of the volume of blood which can enter the maternal circulation. And the next you had to do in this case to prevent the development of so severe complications which are leading even to the death and loss of pregnancy, The next step is improvement of the condition of endothelial system of the patient in health and improvement of the barrier function of the placenta. Just as these patients do nothing which can lead to interruption of the connection between maternal and fetal parts of the conceptus. So, again and again, we're speaking about pathophysiology. Unfortunately, it is still unknown why the sensibility to rhesus-positive antigen is different in different patients. But it is already known that only 15 to 25% of rhesus-negative pregnant women with rhesus-positive fetus inside have incompatibility during pregnancy, and it is dependent on the condition of endothelial system, structure development of the placenta, cause of pregnancy, and immune system of maternal organism. The pathophysiology of isoimmunization involves the following sequence: maternal sensitization against the fetal blood group, which is happened when a couple rhesus-positive female and rhesus-negative female person and rhesus-positive male person conceive rhesus-positive baby. Rhesus isoimmunization is not affect the first pregnancy usually. At the time of delivery, there is entrance of a large amount of blood into the maternal circulation, which is followed with development of antibodies, and next pregnancy, if it would be pregnancy with rhesus-positive fetus, when additional portions of antigen will enter maternal circulation, even less than 0.5 ml of blood, it will follow with specific reaction of increasing of the release of antibodies from maternal organism, and if these antibodies will pass through the placenta, they will affect the fetus as it is shown in this picture, and will lead to development of agglutination reaction on the surface of RBCs, followed with hemolysis, destruction of the red blood cells of the fetus, development of hemolytic anemia, increased level of bilirubin, indirect and direct bilirubin, which will lead to icterus, carnivorous, with development of uncontrolled and treated complication later, and as a maximum manifestation of this process, hydrops fetalis because of lack of the function of the liver, hyperproteinemia, and retention of fluid in the fetal organism. So, maternal sensitization against the fetal blood group antigen is the first step of development of this process. First, fetal antigen had to enter maternal blood, or previously, before pregnancy, some rhesus-positive antigen had to appear in maternal blood. By the way, we already told about blood transfusion of rhesus-positive blood to rhesus-negative women. In our previous practice 30-40 years ago, it had took place rather often, but nowadays we are making only in relation to the using the rule of transfusion of rhesus-positive to rhesus-positive, rhesus-negative to rhesus-negative. But if your patient had it in her previous history, even during the first pregnancy, she already show increased release of antibodies, because previously she already got antigen and released antibodies. These antibodies are circulating in her blood, and additional portion which will take place during the pregnancy will lead to appearance of such a situation just during the first pregnancy, and even more. There are some special scientific investigations which are proving. Listen to me please and be very attentive. Patient may have no previous pregnancy with rhesus-positive blood, really. Patient may have no any blood transfusion at all, not only rhesus-positive to rhesus-negative. But she may present situation which is very closely to isoimmunization, or may present signs of isoimmunization during the first pregnancy if her placenta has failure of function. And in such cases, in some cases, as I told about scientific research, patients who had high rate incidence of acute respiratory viral disease, influenza, may present such a complication because some genotype of influenza virus are very close to the D antigen by its structure. That's why she may present some similar situation. It is not so frequent situation, fortunately, but it may take place. The next step of development of pathophysiology, first is maternal sensitization. We discussed it. Thus, if maternal sensitization is happening, the next step is maternal production of immunoglobulin antibodies, anti-D antibodies. Mother will start to release. Thus, in its turn, the blood, maternal blood, will have increased number of antigen. Think about this point, please, because it may help us to confirm diagnosis if we will be able to check off number of these antibodies, and especially if we would be so attentive that we'll pay attention to the previous presence before pregnancy or just at the very beginning of pregnancy and after 3 to 4 weeks, for example, and more. So maternal production of immunoglobulin antibodies, and the next step we need in passage of passage of these antibodies through the placenta, across placenta to the fetus. If placenta is healthy, it may lead to lack of fetal damage. The presentation of this situation will not so dramatic, but even if the antibody level in maternal organism is not so significantly high, but placenta doesn't make its barrier function, manifestation of process will take place. And the next step, when maternal antibodies across placenta enter the fetus RBCs. It is followed with antibody-mediated hemolysis in the fetal circulation, resulting in fetal anemia, because reaction of agglutination between antigen and antibody will start to be developed, and it is followed with development of hemolytic component, icterus component, and at last with manifestation of process lead to hydrops fetalis with development of the fetus death. So, let me try to discuss maternal sensitization against the fetal blood group, as it is the first step of the development of isoimmunization. What are factors which are responsible for development of maternal sensitization? As we already told, the first is incompatible blood transfusion. I'm absolutely sure that you will not meet such a patients in your practice very frequently, because in very rare cases nowadays we are making transfusion of rhesus positive blood to the rhesus negative person, but it can be done if the only possibility to save the life of this person is this type of transfusion. No any other possibility to save the life. Why not just now we had to save this life? Later we will think about incompatibility, would it happen or not. And the next is fetal maternal hemorrhage. By the way, as one of the preventive mechanisms of development of this situation, for example, in the United States, they are making blood testing before marriage, including rhesus factor. And it may be one of the reasons which will push them to avoid this marriage, if they all have different rhesus factors. So, as about fetal maternal hemorrhage, we told about it already, but let me repeat again. Fetal maternal bleeding is a much more common cause of rhesus D isoimmunization than incompatible blood transfusion, and it is a significant cause of antibody development as well. As demonstrated in 1986 by Bowman and co-authors, 75% of pregnancies have some evidence of transplacental hemorrhage during gestational or at labor, gestational process or at labor. as measured by the sensitive tests developed by Kleiner and co-authors. In 1957, the amount of fetal blood in the maternal circulation is less than 0.1 milliliter. Thus, it is not enough for development of significant number of antibodies, and in this case, isoimmunization would be delayed. In the manifestation, clinical presentation of this situation would be delayed, and fetus demise would be delayed. Antepartum hemorrhage. Because of preterm labor, because of placenta previa, because of vasa previa, because of placental abruption, because of some diagnostic, for example, procedures, chorionuclear samplers, for example, as well as pregnancy-induced hypertension and superimposed preeclampsia superimposed on chronic extragenital disease hypertension. Manual removal of the placenta, which is taking place during the third stage of labor in some patients. Excessive aggravated palpation of the uterus during the third stage of labor. Use of some methods of improvement of the delivery after birth, such as Hentas method, Crida method, as well as, of course, cesarean delivery, which is characterized with rupture, cutting of vessels and amount of blood flow. External version, internal version, which is done during the labor because of transverse lie of the fetus, because of bridge presentation. All of these situations are associated with larger volumes of blood. Enters into maternal circulation, comprehensive with transplacental hemorrhage. Any complication in pregnancy, which is characterized with rupture of even micro vessels in significant presentation of rupture. Pregnancy-induced hypertension, diabetes mellitus, chronic pyelonephritis, glomerulonephritis, which are characterized with lack of function of endothelial system, which may characterize with increased permeability of membranes, full to development of this situation. Operative delivery, caesarean section, venous delivery, application of the forceps and extraction of the fetus with the forceps, as well as intrauterine insertion of the hand with the aim of uterine control after delivery of the fetus and placenta, massage of the uterus on the face. We will tell about delivery of the baby with bridge presentation when we are making extraction of the fetus by the pediatric hand, by the leg, by legs. We will tell about the conservative management of transverse lying fetus, where we need to make fashion of the fetus from transverse lie to cephalic presentation, from transverse to longitudinal lie with the cephalic presentation. We distinguish external version, which is done through abdomen. It may follow with rupture of some small vessels without appearance of bleeding as bleeding, without even appearance of blood staining discharge, but entrance and increasing of the volume of fetal maternal hemorrhage, and especially internal version, which can be done during the second stage of labor with fully dilated cervix, where we are making version of the fetus from transverse to longitudinal but with bridge presentation and trying to take, not trying but making expulsion and evacuation of the fetus, removal of the fetus from the uterine cavity by the leg, by two legs or by pediatric hand. And all of these situations are characterized with increased volume of fetal maternal hemorrhage, and just in labor and in pregnancy they may lead to increasing of the volume of antibodies. If it is chorionuclear sampling, which is done at 15, 16, 13 weeks gestation, and pregnancy prolonged after the not only term but third trimester, why not? Few months is enough for development of isoimmunization just during this pregnancy. But if we're speaking about external version, internal version, cesarean section and so on, usually these situations are not affecting fetus, just this fetus, but during the next pregnancy it will follow with development of isoimmunization. Amniocentesis, which is done for genetic and because of genetic and other indications. We had to do it. It is modern type of management. We are able to confirm diagnosis. We had to exclude the presence of some specific chromosomal and other hereditary diseases. But in its turn, they are also associated with increased risk of maternal sensitization if this patient is rhesus negative, particularly if the placenta is transversed during amniocentesis. Not to avoid such a situation, but to diminish the incidence of this situation, we are making amniocentesis under the control of ultrasound guides. And it helps us to avoid puncture of the placenta during this manipulation. Even if it is risky, we had to make it because it is absolutely indicated for our patient. A 5 to 25% incidence of fetal maternal hemorrhage has been identified after abortion, both spontaneous and therapeutic. Especially severe situation may take place when it was spontaneous threatened abortion. We arrested this threatening in prolonging pregnancy, and throughout prolongation of this pregnancy, it may happen the same situation. Enough time for development of antibodies, release of antibodies, and antibodies may cross through placenta, leading to agglutination reaction and development of rhesus sensitization. Not only mother, but development of intrauterine hemolytic disease of the fetus. So, as a conclusion, any outcome of pregnancy, which has happened at any time of pregnancy, will followed with more or less significant bleeding. Thus, it is followed with the development of maternal sensitization, which have clinical presentation during the next pregnancy if the next fetus is rhesus positive. But if procedure done during the first trimester and pregnancy prolonged, it may lead to development of sensitization and development of fetal hemolytic disease even during this pregnancy. The next step, maternal production of immunoglobulin antibodies. The amount of fetal blood necessary to produce rhesus incompatibility varies. As a rule, less than 1 ml of rhesus-positive blood was shown to sensitize volunteers with rhesus-negative blood. During pregnancy, red blood cells from unborn baby can cross into the mother's bloodstream through the placenta. If the mother is rhesus negative, her immune system treats rhesus positive fetal cells as if they were foreign substances and makes antibodies against the fetal blood cells. Once produced, maternal rhesus immunoglobulin antibodies may cross freely from the placenta to the fetal circulation, where they form antigen antibody complexes with rhesus-positive fetal erythrocytes and eventually are destroyed, resulting in a fetal autoimmune-induced hemolytic anemia with the development of further steps, hyperbilirubinemia and hyperproteinemia with hydrops fetalis development. Once sensitized, it takes approximately 1 month for rhesus antibodies in the maternal circulation to equilibrate in the fetal circulation. 1 month. If we are making intervention during the first trimester, after 1 month, she may present us sensitization and development of a rhesus incompatibility just during this pregnancy. We may have some other situation which are dependent on our interventions. For example, nowadays we are making not cesarean section, but number of situations when we are making surgical intervention during the pregnancy. For example, twins pregnancy with the development of fetus-to-fetus transfusion syndrome. One fetus is presenting donor as about other fetus presenting recipient, and one fetus is suffering from anemia, fetal growth restriction and may die, while another fetus has become very large and feeling good. So what do? We use special surgical intervention to prevent, to make section, communication between two fetus, and then we make stitching, and pregnancy may be prolonged up to viability of both fetuses, for both baby. But if it is done during pregnancy in patient with the rhesus negative blood but with rhesus positive fetuses, it will follow to the appearance of such a situation. After 1 month, this baby may die because of rhesus incompatibility. In 90% of cases, sensitization occurs during delivery. Therefore, most firstborn infants with rhesus positive blood type are not affected because the short period from first exposure of rhesus positive fetal erythrocytes to the birth of the infant is insufficient to produce a significant maternal immunoglobulin G antibody response. The risk and severity of sensitization response increases with each subsequent pregnancy involving a fetus with rhesus positive blood. In women who are prone to rhesus incompatibility, the second pregnancy with the rhesus positive fetus often produces a mildly anemic infant, whereas succeeding pregnancies produce most seriously affected infant who ultimately may die in utero from massive antibody-induced hemolytic anemia. Here are steps: maternal production of immune antibodies, immunoglobulin G antibodies, then transplacental antibody passage to the fetus. During this pregnancy, it is shown as maternal antibodies. Here are maternal red cells without antigen. Maternal antibodies produced against fetal red cells, and when they enter fetal RBCs enter maternal circulation, it is followed with development of maternal antibody, and the next maternal antibodies produced with the which pass across placenta, causing fetal red cell lysis. It is written here that it is next pregnancy, but we talked about 1 month, thus numerous situations may lead to development during this pregnancy. This situation means complicated course of pregnancy. Thus, steps which are presented on this slide: maternal production of immunoglobulin G antibodies, and then transplacental antibody passage to the fetus, then antibody-mediated hemolysis in the fetus circulation resulting in fetal anemia. So, if the fetus antigen transports through placenta into maternal circulation, it is followed with development of maternal antibodies. It may take place, I repeat again, even during the first pregnancy if placenta, here is the barrier, has lack of its function. Thus, it may enter maternal circulation through the placenta, and if placenta is lacking its function, released antibody after 1 month may enter again to the fetal circulation, leading to destroying of the RBCs and development of hemolytic anemia. Most frequently, classically, it is happen in previous pregnancy, and this stage is happen in the next pregnancy. But we already prepared for the next pregnancy, and just from the very beginning we'll present special management, and it would be the next step of our discussion for today. Thus, as for me it is of great importance that we pay attention again factors responsible for passage of antigen and antibodies through the placenta. Lack of placental development, congenital abnormality, increased permeability of endothelial layers of placental vessels, failure of placental structure function due to trauma, detachment, extragenital diseases, etc., etc. In common, failure of barrier function of the placenta is responsible for passage of both antigen of the fetus to maternal circulation and maternal antibodies against this antigen through placenta into the fetal circulation with development of agglutination reaction which is taking place on the surface of RBCs. And options for penetration of antibodies through the placenta. It may take place during pregnancy, which leads to congenital form of hemolytic disease of a newborn. It may take place during labor, which leads to development of postpartum icterus of a newborn. So also known as hemolytic disease of a newborn. First is hemolytic disease of fetus. Second is hemolytic disease of a newborn if it has happened during the labor process. Risk factors for rhesus incompatibility. Now, of course, the most important risk factor is mother rhesus negative while father is rhesus positive. It is already the greatest risk factors. But it doesn't mean that this couple will avoid to get child. So, what are risk factors? In previous history, patient has artificial abortion and anamnesis. That's why we are giving education to all of our patients, trying to prove them that it is absolutely necessary to avoid to make artificial abortions, especially during first pregnancies. Though what does it mean? Patient may come to me for the first antenatal visit, for the booking visit, with complaints about signs of pregnancy, lack of menses, menstrual delay, breast engorgement, MDP, nausea, vomiting in pregnancy, questionable probable signs of pregnancy, and so on and so on. I'm asking her about previous anamnesis, and she's telling me that it is her, she's going to have labor firstly, or childbirth firstly in her life. She never had childbirth. No children at home, but you had to pay attention to the presence of pregnancies, number of pregnancies and outcomes. Maybe she had artificial abortion and anamnesis. She already immunized if the baby within this abortion was rhesus positive, if she conceived previously rhesus positive fetus. It may be spontaneous interruption of pregnancy. Thus be attentive in this situation. Miscarriage in previous history. Any miscarriage, early, late, preterm delivery, previous miscarriage already followed with entrance of amount of blood of the fetus antigen into maternal blood circulation and development of isoimmunization. She already has basis for development. He already immunized. It is a special term which is used for this situation. Immunized. Incompatible blood transfusion in previous history. Next is ectopic pregnancy. Ectopic pregnancy is characterized with interruption at early stages. And most types of it may be spontaneous interruption, or we may make a surgical intervention to arrest this pregnancy, to take it out, to prevent hemorrhage shock and death mother because of the hemorrhage shock. Thus it is followed with fetal-maternal hemorrhage, which is more than 1 ml of course, and she already immunized. Lack of specific prophylaxis after previous pregnancies. After previous not only pregnancies, but not after previous after any outcome of previous pregnancies. We will tell about it after a few minutes, but please pay attention. Incorrect management, great mistake. Patient had delivery with rhesus positive fetus. We didn't make specific prophylaxis, or she decided to make artificial abortion as elective abortion, for example, in some countries it is legal, or as medically indicated medical abortion, therapeutical abortion. We usually don't don't check up the rhesus factor of these conceptors. Even if it is interruption of pregnancy happen as spontaneous abortion, we are not making these tests. But for all of cases, we are making specific prophylaxis if this patient is rhesus negative. Next is development of incompatibility in previous pregnancy and diagnostic manipulations, chordsynthesis, amniocentesis, and so on and so on. Mostly we already told about it, we will repeat it again during the first stages of our discussion today. So, what risk factors must be elicited on history? Maternal history, rhesus negative blood group, younger 16 years, older than 35 years maternal age, rhesus negative woman partnered with rhesus positive father, history of previous blood transfusion. As about obstetrical history, history of jaundice, congenital malformations, stillbirths or intrauterine death in previous pregnancies, previous history of hydrops fetalis, previous history of fetal-maternal transfusion, for example, placenta previa, vasa previa, abruptio placenta. History of receiving or sometimes patient may have intrauterine fetal death during previous pregnancy, and these fetus may not expand from the uterus cavity within a short period of time. It is arresting of the dead fetus in the uterus cavity lead to development of autolytic process and substances which are resulting with this lytic process, presenting thromboplastic substances, and they are entering maternal circulation. On one hand, they are leading to development of disseminated intravascular coagulation. On the other hand, they are leading to development of isoimmunization in such a patient because the release of specific antigen against these antibodies against this antigen. So, previous history of hydrops fetalis, previous history of fetal maternal transfusion, history of receiving of anti-rhesus immunoglobulins in previous pregnancies, decrease in fetal movement. What's happened? Why she has decrease in movement? Because of suffering from hypoxia, distress, even may lead to the death if we will not pay attention to this point. History of unrecognized miscarriage with transplacental hemorrhage. These are maternal and obstetrical risk factors which have to be recognized exactly on patient history, and these are presented according to the most useful protocols. I've got it from Indian protocol, that's why I try to be attentive to this point. It is important to recognize detailed obstetric history from the patient, to get detailed obstetric history from the patient. Previous history of neonatal death or stillbirths and history of previous successive fetuses affected by jaundice, anemia, etc. is quite suggestive for rhesus immunization. Women may typically give a history of having received injection of anti-rhesus immunoglobulins in previous pregnancy or following miscarriage and invasive procedures like amniocentesis, cesarean section, etc., etc. And now, how we will manage patients which are rhesus negative but unsensitized? It is really first pregnancy and she has no signs of sensitization, no factors, risk factors for sensitization in her previous history, no presentation of sensitization during this pregnancy. So, how we will manage this patient? Type and screen of both patients at initial visit. We had to check up not only blood group and rhesus factor of expected mother, but blood group and rhesus factor of her partner. Maternal antibody screening, which helps in detecting the presence of anti-D antibodies, must be performed in all pregnant women who turn out to be rhesus negative. In this test, the maternal serum is incubated with rhesus-positive erythrocytes and comb serum antiglobulin antibodies. The red cells will agglutinate if rhesus antibodies are present in the maternal plasma, and you will visualize it, you will see it with your own eyes. There are special reactions which are showing us and giving possibility to mount the number of titer. We will use it in our practice, but now we are speaking about very simple traditional basic evaluation of the agglutination. Kleine test, very widely useful abroad. This is a blood test usually performed in rhesus-negative mother for measuring the amount of fetal hemoglobin transferred from a fetus to the mother's bloodstream as a result of fetal maternal hemorrhage. It is based on the principle that the fetal hemoglobin is resistant to acid. In this test, fetal hemoglobin is resistant to acid, while maternal adult hemoglobin is not resistant. So, in this test, maternal blood smear is exposed to an acidic solution, citric acid phosphate buffer. The acid is able to elute adult hemoglobin, but not fetal hemoglobin, from the red blood cells. As a result, on subsequent staining, the fetal cells containing fetal hemoglobin appear rose-pink in color, while adult red blood cells appear at the costs very pale. And Kleine test is normally not useful, and it is usually not done to determine the requirement for rhesus immunoglobulins. Here is presented the picture. Kleine test when fetal RBCs showed and they are reddish in color, while adult red blood cells are only seen and some insignificant hosts. Management of rhesus-negative non-immunized women. I will repeat it as fast as possible. Mother is rhesus-negative, father is rhesus-positive. We had to check up maternal antibody titer. We are making it exactly at 28 weeks gestation. If need, we'll make it earlier and will continue throughout the pregnancy. If maternal antibody serum screen is negative, administration of 300 mg of immunoglobulin is necessary at 28 weeks with prophylactic aim. At delivery of the baby, the rhesus status of the baby had to be evaluated as fast as possible, and if the baby negative, do nothing. If baby is rhesus positive, administer another dose, 300 mg of anti-D immunoglobulin within 72 hours after delivery. Other situation, maternal antibody screen shown positive result. Managed as rhesus-sensitized pregnancy, amniocentesis for estimation of the fetus bilirubin level optical density had to be evaluated, and dependent on the result of optical density of bilirubin, we will choose the most appropriate management. We will tell about it during next minutes. So, now, management of the rhesus-negative, unsensitized pregnant woman. Anti-D, how to prevent isoimmunization. Anti-D immunoglobulin can prevent rhesus-negative, non-sensitized mother from producing anti-D antibodies when exposed to rhesus-positive, D-positive blood. A dose of 300 microgram is useful to prevent isoimmunization in pregnancy and decreases risk of sensitization to less than 0.2%. To prevent immunologic response, mother should not be sensitized against the rhesus factor. The antigen should be treated at 28 weeks of gestation. Thus, conclusion, if mother is not sensitized, it is the first pregnancy, and she is pregnant with fetus positive, rhesus positive fetus, or rhesus negative, why not? No sensitization. We will try to avoid to make puncture. Thus, we will try to avoid to increase sensitization. And at 28 weeks gestation, we will give 300 microgram of so-known ROGAM, Indian drug, to prevent sensitization. Next, we had to make decision, modern time of delivery. Timing of delivery for rhesus-negative non-immunized women. In rhesus-negative non-immunized women, the pregnancy must be allowed to continue up to term. However, the tendency to overrun the expected date of delivery must be curtailed. If the newborn has rhesus-positive blood, within 74 hours after delivery, 300 microgram of anti-D had to be entered to the child. If you remember, I told about incorrect management when we didn't make specific prophylaxis. Specific prophylaxis and specific treatment means 2 doses which are given one after another, 28 weeks gestation and within 24 to 72 hours after delivery of a child who is rhesus positive. Delivery of child give possibility to evaluate rhesus factor. If rhesus negative, not necessary to enter again. If positive, make it. And at last, management of the rhesus negative immunized woman. She had sensitization before pregnancy. She got it during the pregnancy, both. In rhesus immunized women, the main objective of the management is to diagnose and treat fetal anemia as soon as possible. This can be done through the following ways. Measurement of the peak systolic velocity of the fetus middle cerebral artery. This is done by Doppler ultrasound. Amniocentesis and amniotic fluid analysis that involves determination of bilirubin concentration in the amniotic fluid. By the way, amniotic fluid gives possibility to evaluate rhesus factor of the fetus and blood group of the fetus. So it is widely useful nowadays. Ultrasound examination of the fetus and percutaneous umbilical cord blood sampling. Coda synthesis. These are most accurate methods of evaluation. Additionally, we are making some other methods and the next slide will show it. So, management of rhesus negative sensitized women. Accurately assess gestation age with early ultrasound. Everybody understand why it is necessary. Determine paternal blood type. Everybody understand why it is necessary. For this rhesus negative, we have no problem at all. If the partner is rhesus negative, there is no need for further evaluation and intervention. If the partner is homozygous for D, the fetus is D positive exactly. If the partner is heterozygous for D, the fetus has 50% chances of being rhesus negative and not at risk for hemolytic disease so frequently. In amniocentesis of chorionic villus sampling, DNA analysis can be performed to evaluate whether the fetus is rhesus positive. Management, continuation, assess prior obstetrical history. We already told about risk factors which are leading to development of hemolytic disease during the next pregnancy. So, if mother had a previous hydropic fetus, the risk that the next rhesus positive fetus will become hydropic is very high. It is closer to 80%. Hemolysis and hydropic changes usually develop at earlier gestation age with age successive pregnancy, earlier and earlier with age successive pregnancy. In general, the risk of severe fetal hemolysis and hydropic changes in the first sensitized pregnancy is low. In general, but not exactly. Assess antibody titer. I told that we will tell about some additional, not so accurate methods of exam, and it may be used at any hospital, not exactly tertiary hospital, not exactly in the secondary hospital. You may make it at any situation. Antibody titer. In the first sensitized pregnancy, titers should be drawn every 2 weeks to assess the need for amniocentesis. Not only to assess the need for amniocentesis, but to understand what is the development of this process. Amniocentesis should be offered when the critical titer is reached. As about critical titer, not so absolute level, but we had to understand if the titer is 1 to 16, fetus has been severely anemic. Next step had to be done individually depending on the term of pregnancy, depending on previous analysis and further development of the situation. The critical titer is laboratory specific. In subsequent sensitized pregnancies, antibody titer is not as useful as a guide to the timing of amniocentesis. The patient's history should be used to guide the timing of invasive testing and intervention. Serial ultrasound scan monitoring had to be done every 2 weeks. Pay attention please. The only sentence in this slide, every 2 weeks, comprehensive with normal cause of pregnancy, not in rhesus negative patient. We are making 3 times a pregnancy, 11 to 30 weeks, 22 to 24 weeks, and before delivery 34 to 36 weeks gestation. Here we will make it every 2 weeks, paying attention to the special symptoms, features of hydrops fetalis. If antibody level continue at the same level and no fetal compromise, deliver at term. No changing of antibody titer. I told that it is not fundamental, not accurate, but it is so routine, but it can help us. For example, just from the very beginning, she had 1 to 2, no, I don't know, 1 to 8 antibody titer, and no changing at all throughout the pregnancy. Continue, prolonged pregnancy up to the delivery term. Observe fetal condition development with other additional methods, CTG, Doppler, as we had to make it for any patient, screening, and so on. But this is the rule. If antibodies levels start to increase, use amniocentesis to assess degrees of hemolysis and risk for fetal death. Once invasive testing is initiated, further assessment of antibody titers is not indicated. The decision about further management is dependent on the level of bilirubin, because level of bilirubin will show us degree of the fetus compromise. Bilirubin in amniotic fluid is a high byproduct of fetal hemolysis. Bioproduct. Bilirubin enters the amniotic fluid from fetal secretions, and the level of bilirubin in amniotic fluid correlates with fetal hemolysis. Spectrophotometry is used to assess the level of bilirubin in amniotic fluid to evaluate fetal condition. Transabdominal amniocentesis may be used after 26 weeks of pregnancy. With this procedure, we will get the portion of amniotic fluid to make previous test. Spectrophotometry against the 450 nanometers of the wavelength, and evaluate antibody titer, evaluate presence of protein, number of protein, evaluate rhesus factor, and evaluate level of bilirubin to make final decision what is the management. So, indications for amniocentesis. It had to be done after 26 weeks. Please remember it. And indications: antibody titer 164 or more, increasing titer 4 times in the second study after 2 weeks, not 164 but increase 4 times within 2 weeks, increasing titer with the periods of ultrasonic signs of fetal hemolytic disease. I will show you ultrasonic signs of fetal hemolytic disease: stillbirth, delivery of a newborn with hemolytic disease in anamnesis, and ultrasonic signs of fetal hemolytic disease. These are indications for transabdominal amniocentesis. And here is presented table. I propose to learn it by heart because it is evaluation of degree of fetal hemolytic disease depending on optical density of bilirubin in amniotic fluid, which is taken by abdominal amniocentesis. So if the optical density of bilirubin is 0.15 to 0.20, it means that the risk of fetal compromise is low, maybe the first degree of hemolytic disease. Thus we can try to prolong this pregnancy with observation. 0.2 to 0.34, risk is moderate, second degree. 0.35 to 0.7, high risk for the fetus, third degree, and more than 0.7, very high risk of the fetal death. Maybe already dead, maybe dying, but it is very, very severe situation. Thus, dependent on the risk, dependent on the level of bilirubin, we will make decision. For example, 34 weeks, 0.35 to 0.7, I will make cesarean section. In the United States, they are making cesarean section at 24 weeks for such a patient's fetus. In tertiary hospital, we are making it to have possibility for resuscitation of this baby and further management, because it is very deeply preterm baby. Here are features of fetal hemolytic disease: hydrops fetalis, hyperbilirubinemia, by the way, followed with hypersplenomegalia. In turn, amniocentesis is associated with an increased risk of sensitization, infection, rupture of membranes, and fetal loss. So there are some contraindications for amniocentesis: threat of preterm labor, fever. Perform chordosynthesis when it is believed that the fetus is at risk for severe anemia. These techniques should be performed within a 22-gauge spinal needle under ultrasound guidance. This technique may be performed along any portion of umbilical cord, preferably in the umbilical vein. We will get some portion of blood to make a special lab test for diagnosis, and if necessary we can perform fetal transfusion either intraperitoneally or intravascularly with the help of this percutaneous umbilical cord sampling, and it can help us to support the fetal oxygenation with the entrance of donor RBCs to the fetus, which will help us to prolong pregnancy up to the more viable fetus term. So donor cells had to be matched with the mother and fetus. Donor cells are washed, irradiated, filtered, and suspended in normal saline to a hematocrit 70 to 75%. Once transfusion is complete, the final fetal hematocrit is assessed. And compared with amniocentesis, the risk of infection, rupture of membranes, fetal loss, and fetal sensitization even higher. Here is presented the picture how we are making percutaneous umbilical cord blood sampling, or chordosynthesis. Chordosynthesis, also sometimes called percutaneous umbilical cord sampling, is a diagnostic procedure which is done for a number of diseases, including Down syndrome and detection of isoimmunization. May be performed during 18 to 24 weeks gestation. Treatment for fetal hemolytic disease. Intrauterine transfusion. It may be intraperitoneal. Hold up to 22 weeks in pregnancy, or in the intravascular transfusion if it is possible. The abdominal cavity, the wall of the uterus abdominal, the fetus punctured. With then rhesus negative red blood cells, as we already told how to prepare, filtered, washed, filtered, and resuspended, of the same group had to be introduced, and one absorbed by the lymphatic system reached the vascular system of the fetus and helping us to support his vital function. And intravascular, under the control of the ultrasound, we are making puncture of just of umbilical cord vein, for example, chordosynthesis, and enters of special volume of blood, which is specially prepared, as we already taught during previous slide. And conclusion, antenatal management of immune rhesus negative pregnancy. I will not repeat it again because we discussed. I hope you see fit for further studying. So, other methods include ultrasound, Doppler velocimetry, CTG, biophysical profile, and so on, as we already told. Sonographic features. Ultrasound assessment of fetal hemolytic disease includes evidence of polyhydranous, placental thickening, pleural effusion, pericardial effusion, ascites, increased liver size, suggestive for extramedullary hypopoiesis. Pay attention please, the placenta had to be thicker, more than 15 millimeters. Hypertrophic and edematous placenta is one of the other signs of rhesus immunization in pregnancy. It is written that before 30 weeks, ultrasound should be done once a month, after 30 weeks 2 times a month, but now they were trying to make it 2 times a month. Sonographic features of fetal hydrops fetalis. Fetal ascites shown here, pleural effusion, scalp edema, crown-like ring around the head, ascites. Fetal hypermegaly, splenomegaly. And there is some other symptom which may be more easy to you to remember. Buddha pose of the fetus in the uterine cavity as it is shown in this picture. Fetus has attitude of extension. Fetus has size of ascites. Fetus is sitting as Buddha sitting. No, not exactly, but it is known as Buddha pose. It means that there is severe abdominal swollen of all the parts of its body. Doppler velocimetry assess the increased peak velocimeter in the fetal middle and cerebral artery and abnormal velocities in fetal aorta, inferior vena cava or umbilical vein. Here is the picture demonstrating cerebral artery, middle cerebral artery, systolic maximum blood flow velocity, very high. Sinusoidal fetal heart rate pattern on cardiotocography and timing of delivery. If there is no signs of fetal hemolytic disease, the pregnancy can be continued up to the term. Not up to 38 to 40 weeks, but up to the term. In case that there is evidence of fetal hemolytic disease, early termination of pregnancy may be considered. If the period of gestation is 36 weeks or more, the labor must be induced. If the period of gestation is less than 36 weeks, chordsynthesis might be done to determine fetal hemoglobin level hematocrit. If hematocrit is less than 30%, fetal intrauterine blood transfusion, we already told about it. At 10 to 14 days intervals had to be done until 34 or 36 weeks when the fetus is more viable. Following the intrauterine blood transfusion, delivery is usually performed in 37 weeks gestation. Indications for early delivery increases is isoimmunization, antibody titer 1 to 60 for immediate delivery. The titer increases 4 times when repeated. The level of bilirubin is more than 4.7. Ultrasonic signs of fetal hemolytic disease are present, was presented in previous slides. Stillbirth and delivery of newborn with hemolytic disease in previous history. And interpartum management. Following steps must be taken to minimize the chances of fetal maternal bleeding during the time of delivery. Prophylactic ergometry with the delivery of anterior shoulder, routinely administered as a step on the active management of the third stage of labor, must be done. If the manual assistance of the placenta is required, it should be performed gently in order to minimize the chances of the fetal maternal bleeding. Rhesus positive blood transfusion must be preferably avoided in rhesus negative women right from upper up till menopause. And after delivery, 300 microgram of anti-D immunoglobulin had to be entered within 74 hours. Careful fetal monitoring had to be done. Delivery should be as non-traumatic as possible. The clinician should remain vigilant regarding the possibility of the occurrence of PPH, postpartum hemorrhage, since ergometry is usually entered. Umbilical cord should be clamped as soon as possible to minimize the chances of fetal maternal hemorrhage, and about 5 centimeters of stump had to be remained because we had to need intra-umbilical transfusion in later management and replacement blood transfusion. And immediately after delivery of the fetus, constrict and cut of the umbilical cord to avoid inflow. With cesarean section, placenta doesn't separate the hen. After delivery, raw gam had to be added, is already told. Treatment of hemolytic disease of a newborn. Exchange transfusion. We will transfuse, pay attention, rhesus negative blood of the same group with validity of no more than 3 to 4 days in an amount of 120 to 150 milliliter per kg of body weight. Exchange transfusion. I will read if I will have time, but I want you to save it. The exchange transfusion will enter rhesus negative blood of the same group to the fetus. Fetus is rhesus positive, but we are entering rhesus negative to make solving of the concentration of maternal antibodies which are circulating in the blood. To ensure that it is effective, we had to check up. The volume of bilirubin. In the presence of rhesus isoimmunization, cord bilirubin level of more than 5 mg per deciliter or a rate of rise of serum bilirubin of more than 0.5 to 1 milliliter per deciliter per hour is predictive of the ultimate need for exchange transfusion. This relationship has not been demonstrated in hyperbilirubinemia of other etiologies. A report of supplemental intravenous fluid administration in 74-term babies with non-hemolytic severe hyperbilirubinemia demonstrated a decreased risk of increased exchange transfusion in babies receiving the extra fluid compared with control. So the procedure involves removal of the baby's native blood and replacing with a citrate phosphate dextrose CBD banked blood that doesn't contain bilirubin. What type of blood to give to the fetus? Exchange transfusion, fresh whole blood less than 7 days old, intrauterine transfusion, RBCs, group O, D negative, maternal blood if possible, LACA reduced. Treatment of hemolytic disease, phototherapy would be administered for this patient, infusional transfusional therapy to reduce the number of circulating antibodies and to reduce the number of hemolyzed erythrocytes. And within the first day postpartum, every hour we had to evaluate the rise of bilirubin, hourly rise bilirubin. Later, when it became constant, we had to use neonatal intravenous immunoglobulins in a dose of 400 microgram per kg daily for 3 days. It had to be combined with phototherapy. And as about ABO group incompatibility, they are weak hemolysis, less clinical presentation, and practically they are similar without so severe outcome for both mother and the fetus. Thank you for your attention. I hope it will help you to prepare for your independent work later. Да-да, флешку. Дима, спасибо большое.
Да, не за
знаю,
что.
как нам все прошло. Что такое 000? Вот эта активность, это что, никто не смотрел? Что-то они тут мелькали.
Ну, они смотрели, 16 человек-то вон как минимум